Welcome everybody to this another episode of the INOS International Webinar. Today we are going to have some very outstanding presentations and speakers. It's going to be a lot about understanding the ocular motility disorders and interpreting them, localizing them. And we have some outstanding speakers both from the US and from India. And of course, we have an excellent panel with us who will be discussing any questions that you have and any questions that arise from the presentations that are made. I'll just request the host to mute everybody else other than the speaker so that we don't have any disturbances. We are going to start with Dr. Daniel Gold. It's very difficult to actually in one breath say all the experience that he brings with himself. He is a professor of neurology, ophthalmology, neurosurgery, otolaryngology, surgery, emergency medicine, and medicine. And he's from the Johns Hopkins Hospital. He's been associated with Neurologists of India with the FINE network. He has been a frequent traveler and presenter at Latin America in numerous neuro-ophthalmology meetings. His case series and videos are outstanding. If you go onto the Novel Network, it's amazing to listen to his clarity of thought and his presentations. He's going to talk to us about the ocular motor and the vestibular examination and how to crack it and understand it. So, Dr. Daniel, the stage is for you.
Great. Thanks so much. It's an honor to be here. Let me share my screen and get started. Please stop me if the videos look bad for some reason or choppy, but I've just optimized screen share, so hopefully it should be okay. All right. So again, it's an honor for me to be here. Thanks so much. As an aside, this is actually a holiday weekend, so I'm with my family. We have to get out of this rental house in the next couple minutes, so I'll have to leave you after 30 minutes. My apologies, but this is a tough topic. Obviously, ocular motor exam is very relevant, but these patients, whether you like it or not, who have vestibular symptoms will also arrive in your clinics. So it's a good idea to know something about the vestibular exam, what to do, what these symptoms might suggest. So we'll talk about the approach. I've given this talk a couple times. Now this is the 2020 pandemic version now with some virtual telemedicine pearls. I don't know how many people are doing telemedicine out there, but some of these exam maneuvers and strategies can be quite effective, some not so much. Okay, so what we'll talk about is how do I examine the ocular motor system to diagnose. I guess we have a couple people who are unmuted. Okay. To diagnose and localize a central vestibular disorder or just a complicated eye movement disorder, how do I examine the semicircular canals to diagnose and localize a peripheral or central disorder? How do I examine the utricles? Perhaps these are structures that you haven't thought about in a while, but I'll hopefully by the end it'll be clear to you why this is relevant. So first, examining the ocular motor system. So first, there are a lot of structures here. There's a lot of important real estate here in the brainstem. We're talking about the ability to make saccades. We're talking about the rostral interstitial medial longitudinal fasciculus to make vertical saccades, or for torsional fast faces. That's the RIMLF. If we're talking about the horizontal saccades, the burst neurons, they live in the paramedian pontine reticular formation, the PPRF. If we're talking about making a saccade vertically and wanting to keep the eyes in up gaze or down gaze, there has to be some gaze holding machinery that does that. So the interstitial nucleus of Cajal is going to keep the eyes vertical in an eccentric position. Where horizontally, we make a saccade with the PPRF to the right. Now we want to keep the eyes there. Now we're talking about the nucleus prepositus hypoglossi, as well as the medial vestibular nucleus. What about the cerebellum? The cerebellum really fine tunes these eye movements. So You make a saccade to the right or up or down. You keep the eyes there. You're using the interstitial nucleus of Cajal or the NPH, but the flocculus and the paraflocculus, also known as the tonsil, are really going to enhance those gaze holding abilities. They're going to allow you to pursue something smoothly. They're also going to inhibit anterior canal pathways, which may be one theory for why some patients have spontaneous downbeat nystagmus when they're just looking straight ahead. The ocular motor vermis and the vestigial nucleus are very important for saccade accuracy, the ability to make a saccade from right to center and keep the eyes without overshooting or without undershooting. We'll see examples of each. And the nodulus and the uvula have a big role to play in velocity storage. We're not going to get into that. So again, we're not going to get into the nitty gritty of any of these structures per se, but by taking a methodical approach to the exam, evaluating vertical movements and horizontal movements, and knowledge of the neuroanatomy can really allow you to localize to a specific nucleus here or there, or this is on the right side of the brainstem here. So you really have to have an understanding of the machinery prior to performing your ocular motor exam. Okay, so first, we're going to talk about, right, in every patient, we just want to make sure that they can, their eyes are steady when they're looking straight ahead as well as out to the right, left, up, down. Is there any gaze-evoked nystagmus? Does the patient have any spontaneous nystagmus or saccadic intrusions or oscillations that might be meaningful from a localization or from a diagnostic standpoint? And everybody here has seen many sixth nerve palsies throughout their careers, but just the ophthalmoplegia in general, as we know, it can be supranuclear, nuclear, fascicular, or neuropathic, or neuromuscular, or myopathic. But really, if you're going to check saccades in pursuit and the vestibular-ocular reflex, you have to understand how well or not well the eyes can move. Also, if we're talking about the vestibular exam, maybe we're going to put video head impulse goggles or perform video oculography on this patient. And knowing that he has an abduction paresis is really going to affect our ability to interpret the vestibular exam as well. So these are some examples of abnormal fixation. So clearly this patient has spontaneous nystagmus. The eyes are constantly drifting down. That's the slow phase, and then up. That's the fast phase. This is an upbeat nystagmus. This is jerk nystagmus, the slow phase, which is the pathologic phase, followed by the fast phase, which is the position reset mechanism. This is a patient with thiamine deficiency, Wernicke's encephalopathy, who presented to the emergency department. Compare that to another form of nystagmus. This is pendular nystagmus. So there's no slow phase followed by a fast phase, but these are just back-to-back-to-back slow phases that look like a pendulum. If you look at the back of the palate in this patient, you'll see that there's a palatal tremor that's also synchronous with the pendular nystagmus. What about saccadic intrusions or oscillations? This patient has ocular flutter. This is a post-infectious phenomenon in this particular patient. These very fast back-to-back-to-back saccades with no intersaccadic interval. So again, recognition of these allows you to really understand what's going on in the brainstem or the cerebellum and can really help from a diagnostic standpoint substantially. Okay, what about abnormal gaze holding? So in this case, there's right beating, nystagmus, and right gaze. Now she looks back to the center, it's left beating, that's rebound. Now she's looking to the left and there's left beating. She can't keep the eyes in eccentric gaze. She looks back to center and again, there's rebound, this transition from left beating and left to now right beating when she comes back. So again, right beating and right, and now left beating in center. So when you see this rebound nystagmus to this degree, this is never going to be physiologic endpoint nystagmus. This is always going to be pathologic gaze-evoked nystagmus. And then you're thinking about the gaze holding machinery in the brainstem. You're thinking about the flocculus and the paraflocculus and the cerebellum. Something's not working right. This is pathologic gaze-evoked with this rebound, not physiologic. What about saccades? I like to check saccades back to my nose. That's really good for accuracy. The patient overshoots or undershoots, it's really easy to tell what's going on. But also evaluating the latency. Some neurodegenerative disorders can cause an increased latency where you ask the patient to make a saccade and a couple of seconds go by. Obviously, the accuracy is saccadic dysmetria, conjugacy, so larger amplitude saccades, to look to see if there's an adduction lag due to an internuclear ophthalmoplegia, as well as the velocity. Again, those larger amplitude saccades are really good for evaluating the velocity of the saccades. Are they slow? Or are they fast? If you can see the eyes moving during the saccade, probably that means they're too slow. Also, the optokinetic, looking at optokinetic nystagmus can also be really helpful to gauge in your mind whether these are too slow or not. So this is a way to test saccades virtually, and this, in my opinion, works out really well, and you can really judge the speed and the accuracy of saccades, as well as the latency is a little trickier, just given the fact that there can be a lag electronically. Okay, so this is an example of dysmetric saccades. So here she has hypometric saccades to the left. And now she overshoots to the right. This is in slow motion, by the way. But again, asking her to make a rightward saccade, she overshoots to the right, and then she has to come back. Again, this is hypometria to the left. Watch, she makes a couple of 2 or 3 little saccades to get to the target. She undershoots. And now again, hypermetric to the right. So hypometria to the left, hypermetria to the right. This is often highly localizing to the lateral medulla. So as in a Wallenberg syndrome, oftentimes the patient will always, in this situation, overshoot toward the side of the lesion, but oftentimes there are other signs. So there might be a right-sided Horner syndrome in her, or other either neuro-ophthalmic signs like a skew deviation, or neurologic signs, loss of facial sensation on the right side, for instance. So again, dysmetric saccades can be highly localizing, as in this case, especially when they're hypometric to one side and hyper to the other. There's this circuitry that connects the brainstem and the cerebellum via the inferior cerebellar peduncle, which is affected with a lateral medullary stroke, to the dorsal vermis, the vestigial nucleus, to the PPRF, to the sixth nerve, or sixth nucleus rather. So again, knowledge of the circuitry, knowledge of the neuroanatomy really allows you to localize the problem. What about smooth pursuit? So you want a small target, you want to go slowly. And this is a normal example. This is an abnormal example. So this is really, really saccadic or choppy. Again, her pursuit, she just can't use her smooth pursuit system to keep up with the target. So she keeps lagging behind. And then she has to make these saccades, these compensatory saccades, to make up for sort of trailing behind the visual target. That's what gives it the saccadic or the choppy appearance. This is really impaired smooth pursuit. This is the same patient that I showed who had the gaze evoked nystagmus. So you can see as soon as you go too far to the right or too far to the left, there's gaze evoked nystagmus. But right in the middle, that's where you care the most about. And you can see how choppy that is. When it's symmetrically saccadic, so horizontally, right and left and up and down, it looks the same. Think of something cerebellar. Then in that situation, you're looking for gaze evoked nystagmus as well. You're looking for gait ataxia. Think about a basal ganglia disorder as well. Parkinsonism, usually Parkinson's disease, doesn't cause saccadic pursuit like this. But PSP, progressive supranuclear palsy, certainly can cause really impaired pursuit. And if that's the case, then you're going to see lots of other ocular, motor, and neurologic signs to suggest that this is a Parkinsonian problem. The reflex. So this is another way. So the vestibular reflex suppression, this is a combined eye-head movement. And almost always pursuit and VOR suppression are going to both be normal or both be abnormal. Okay, so this is another way to evaluate the pursuit system. And just during normal life, you're moving your head all the time. But if your VOR was always sort of the dominant class of eye movements, every time you moved your head, your eyes would move in the opposite direction, would stay put. So there has to be a normal way to suppress or cancel the vestibular reflex. So I can look over here or look over there, and my eyes don't lag behind with the VOR. So you have to be able to suppress the VOR. This works quite well also if you're doing some virtual consultations. This is another way to evaluate vestibular reflex suppression. And it should just be nice and straight. The eyes shouldn't move. There should be no saccadic appearance. This is the same patient who had the really saccadic pursuit. And again, you can see she's just asked to keep her eyes on her outstretched thumb as she's being rotated in a chair. And you can see how saccadic those eye movements are. Again, if you go too far to the right or too far to the left, you'll see her gaze evoked. But in this kind of patient, if you have the patient look straight in the middle, you can really see the VOR suppression. Also, or that saccadic VOR suppression. Also, if a patient has spontaneous downbeat nystagmus, it can be tough to know whether pursuit is saccadic or not. This is another really nice way in patients with nystagmus or intrusions to understand how well or not well the pursuit system is working. So if pursuit is saccadic, the VOR suppression test will be just as saccadic as in this patient, unless there's no VOR to suppress. So if you have no VOR to suppress, the pursuit may look very saccadic, but VOR suppression may look quite good because there's no VOR to suppress. So in order to really interpret this test, you have to have knowledge of how well or not well the vestibulo-ocular reflex is working. Think about a condition called CANVAS, cerebellar ataxia neuropathy and vestibular areflexia syndrome, where there's impaired pursuit due to cerebellar disease, and there's vestibular loss due to a bilateral vestibulopathy. In that situation, pursuit's going to look really saccadic or choppy, but VOR suppression will look much better than that. Again, there's no VOR to suppress. What about convergence? So convergence isn't one of the most important in the sort of ocular, motor, and vestibular battery of tests. Obviously, if somebody has a concussion or Parkinson's disease or PSP, oftentimes they have convergence insufficiency. You'll see a near point of convergence, usually that's greater than 10 centimeters or so. The patient will have binocular horizontal diplopia at near. You want a small fixation target. How else can this be helpful? This is a patient who now she's looking at near. Now she's looking at distance. Now she's looking at near. Now she's looking at distance. Now she's looking at near. So two things are happening when she's converging the eyes. She has upbeat nystagmus. She also has ocular flutter. So two problems, two complicated ocular motor problems, one nystagmus, one saccadic intrusion or oscillations that were both provoked by convergence in her case. She has a history of a pilocytic astrocytoma in the posterior fossa, status post-surgery and radiation and chemo. So this is a situation where actually she just has a teeny tiny little bit of upbeat nystagmus, but convergence really brings out that acquired nystagmus, usually a vertical acquired nystagmus, so upbeat or downbeat. So again, convergence can really increase or provoke acquired nystagmus, usually vertical, or even cause it to transition, as in Wernicke's. So if you see a patient with acute Wernicke's encephalopathy, oftentimes they have spontaneous upbeat nystagmus. If you have them converge the eyes, oftentimes that will transition to downbeat. Also, if you're not sure if this could be congenital or not, or if you know it's congenital, often that will damp with convergence in those situations, the opposite of with acquired nystagmus. Okay, so what about optokinetic nystagmus? This is a true optokinetic stimulus. Looking out of a train window, this is a full field stimulus. This is a patient who has a complete saccadic palsy. I asked her to look out the window, and she has no saccades.
You feel like your eyes are getting stuck there?
So she has the slow phase. The eyes can follow the scenery, but they can't come back. There's no position reset mechanism.
And you can look back forward.
So if you can't generate the fast phases, if you have a saccade problem, then you're not going to be able to generate optokinetic nystagmus. Again, you can see the slow phase. Clearly, she can follow the scenery with her eyes, but she can't bring the eyes back, so she couldn't generate nystagmus. This is a rare sort of a post cardiac surgery cause for a complete saccadic palsy, which is a rare but reported phenomenon. All right, so what do we do in the clinic? So we have our optokinetic flag or tape. We have the patient look at the alternating white stripes or red stripes, and we see the slow phases and the fast phases. Slow phases are pursuit, fast phases are the saccades. We can also do this virtually. I found this to be really effective using one of like an eye handbook app and just holding it up to the camera. That works really well, actually. So you can see clearly a nice optokinetic response in both of these patients. But this isn't really a true optokinetic full field stimulus like the train is. Here's another example of an abnormal response. This patient has normal horizontal optokinetic nystagmus, but he also has bilateral rostral interstitial medial longitudinal fasciculus lesions. And this is a downward slow phase with a little tiny, he can't really generate a good upward fast phase. Now I'm going to flip it over. And now you can see the slow phase brings the eyes up, but he can't generate any downward fast phase. This is very characteristic of a rostral interstitial medial longitudinal fasciculus vertical saccade palsy, where downward saccades are affected more than upward saccades. So another nice example of an abnormal response to optokinetic. And again, he had bilateral rostral midbrain sort of diencephalic strokes. So it also allows just for rapid assessment of saccades in pursuit, conjugacy of saccades, as well as for an internuclear ophthalmoplegia and INO. This can be a really nice way to bring out that adduction lag. What about the semicircular canals here? So what does the bedside exam consist of? The following, we'll go through this. So why should you care? Because these patients who have bilateral vestibular loss and head movement dependent so-called walking oscillopsia will present to you because it's a visual problem for them. And they think it's an eye problem and they go to see the ophthalmologist or the neuro-ophthalmologist. So this patient almost certainly always has bilateral vestibular loss with this walking oscillopsia. Other patients that you will see have sitting oscillopsia. So their head is still, but the world is jiggling. Oftentimes that's from nystagmus, which could be vestibular or from some sort of a saccadic intrusion or oscillation. So again, patient has oscillopsia, either ongoing or periodic, could be a vestibular disorder. So you should have some knowledge about the vestibular exam, the vestibular system for those reasons. This is the visually enhanced VOR. This is a combination of smooth pursuit and the vestibulo-ocular reflex, but not, it doesn't isolate the VOR. So if you have unilateral vestibular loss, the good side can drive the response. For that reason, this really slow VOR, this visually enhanced VOR, is inadequate to measure the vestibulo-ocular reflex function. In this situation, her VVOR is really saccadic. So especially in the middle, here it is in slow motion, you can really see it, especially in the middle. Look how saccadic or choppy that is. Right away, without doing a head impulse, without doing anything, you can say that this patient has two things happening, has bilateral vestibular loss, and has saccadic pursuit. So this is a patient with canvas, cerebellar ataxia, neuropathy, vestibular areflexia syndrome. She has two problems, impaired pursuit due to cerebellopathy and VOR loss due to bilateral vestibulopathy. So again, choppy VVOR, you can automatically say that two systems are affected, the cerebellar and the vestibular. This is a head impulse test. This is Dr. David Z, one of the best in the world performing a head impulse test. And this is a normal response. This is a very high velocity movement, but it's a very low amplitude movement as well. So the likelihood that you're going to hurt somebody's neck is extremely low if you do it right. And again, every time you move the head quickly, the eyes stay right on the target, which is usually the examiner's nose. And this is a perfect vestibulo-ocular reflex. This evaluates the high frequency VOR so that the good side, if you have a unilateral loss, can't drive the response. Pursuit can't compensate because this is just too fast. This doesn't work so well unless the patient has really profound vestibulopathy. All right, this is what an abnormal head impulse test looks like. So again, the head is moved, the eyes go with the head for a split second and then have to make a catch-up saccade. This patient has an abnormal response much more to the left than to the right. And so again, you see that catch-up saccade, everything is easier in slow motion, and the head is moved back to center, and it will go to the left in a second. And again, you can see that really big, prominent catch-up saccade to the left greater than to the right. This patient has bilateral vestibular loss. This is usually peripheral, but it can be due to a lesion or lesions affecting the vestibular nucleus. If you're talking about the acute vestibular syndrome, the patient who is continuously vertiginous and who has spontaneous nystagmus, also think about the possibility of a labyrinthine stroke. So a stroke of the inner ear. If that happens, almost always there's cochlear ischemia as well, so the patient has unilateral deafness. This is something you can easily do if you're not comfortable with the head impulse test. Just check dynamic visual acuity. So this patient can read the 20/20 line, and now with his head being moved side to side and up and down, he doesn't lose any lines. He can still read the 20/20 line. That suggests that his VOR horizontally and vertically is working quite well. So this is an easy thing to do, dynamic visual acuity. This can be done virtually. It's just not as effective because the patient can cheat. They can sort of move a couple times and then stop to foveate on the chart and then keep going. So can be effective. Again, this patient who has bilateral vestibular loss, they're going to lose a lot of lines of dynamic visual acuity here. So if you have unilateral one-sided vestibular loss, usually 2 to 3 lines, often worse horizontal, or if it's bilateral, usually the patient's going to lose 4 or more lines on the visual acuity chart. So how should we perform other pieces of the vestibular exam? It's always helpful to remove fixation. Frenzel goggles, these +20, +30 diopter lenses can be really handy to remove fixation and allow for magnification and illumination. Video goggles can be really nice as well. They're infrared, the patient's completely in the dark. If you don't have these fancy goggles, you can just simply do the pen light cover test, where essentially you're occluding one eye and you're sort of blinding the other eye with a bright light, which effectively is going to remove fixation, not completely. Or you could perform occlusive fundoscopy, where again, you've really completely removed fixation. This is a little bit more technically challenging, but certainly not for this audience. So what about head shaking? So this is something that we can do. This is a 2 to 3 hertz movement for about 15 cycles, and this can bring out vestibular asymmetry. If present, it takes 15 seconds. It's a very easy test to do, and I'll show you the kinds of situations where it can be helpful. Again, there's no response here. Nothing's happening because this patient's vestibular system is intact. This can work virtually as well. And again, here's an example of a pen light cover test performed at home by the patient. So what does it look like if it's abnormal? This patient has Ramsay-Hunt syndrome on the left side 4 months ago, didn't have any spontaneous nystagmus, but every time you shook his head like this, you see this head shaking induced nystagmus that's right beating. It's contralesional when it's peripheral. This is what it should be. Again, the slow phase drifts towards the paretic left ear in this case, and then you see the right beating nystagmus. This transiently is going to increase vestibular asymmetry and cause this head shaking induced nystagmus. This is a nice example. And again, if something happened months ago, this is something you can easily do at the bedside to see if there was any vestibular asymmetry, if this patient is compensated, or probably if that's not the case. There are central patterns of this as well. So a patient has a little bit of gaze-evoked nystagmus or saccadic pursuit. You shake the head and you see downbeat nystagmus. If you see downbeat nystagmus with horizontal head shaking, that's called cross-coupling. And that is a central pattern in this situation. Also, if you have no unilateral vestibular loss, but you have a really robust head shaking induced nystagmus, that's another central sign. But again, if you have this downbeat nystagmus, this cross-coupled response, you're thinking about a problem with the vestibulocerebellum. The vestibulocerebellum consists of the flocculus, paraflocculus, as well as the nodulus and uvula. All right, what about vibration? So we apply vibration to the mastoids, the vibration and the vertex as well. The vibration is transmitted symmetrically and bilaterally. This is another nice way to bring out vestibular asymmetry. What does it look like? This is another patient with a left-sided vestibular neuritis. And every time we vibrate his mastoid, you can see that right beating nystagmus time locked to the vibration. Again, vibration's off, vibration is
vibrate
on. Now you see that right beating nystagmus again, time locked to the vibration. And again, this is contralesional. The slow phase is going to drift towards the paretic ear. At home, you can do this with an electric toothbrush to vibrate the mastoids. That works pretty well. Finally, what about the utricle? So we'll talk about ocular alignment, fundus torsion, and subjective visual vertical. So first, what is the physiologic ocular tilt reaction? So here's me on my motorcycle. You can see how comfortable and confident I look here. This is a great review of skew deviation. It's about 25 pages of nothing but skew. It took me about 55 times to read and fully understand, but it's a great article. So what happens if I'm on my motorcycle and I go around a curve to the right so that my body, my motorcycle, and my head are all leaning to the right? If I tilt my head to the right or lean to the right, that's going to excite the right utricle. And when that happens, the right eye is going to elevate a little bit. There's going to be a little skewing of the eyes, which is minute in a normal person. Right eye is going to elevate a little bit. Left eye is going to depress a little bit. And there's going to be an ocular counterroll. So the top holes of the eyes, in an effort to keep the top holes of the eyes sort of vertical relative to Earth, to gravity, the eyes are going to counterroll a little bit. These are really minute responses in a normal person as part of the physiologic ocular tilt reaction. What really happens is that normal people just reorient their heads to gravity. So there's a reflexive reorientation of the head back to gravitational vertical. That's the major component of the ocular tilt reaction. So then what does a pathologic ocular tilt reaction look like? Usually due to a brainstem lesion. So let's say that there's a right utricle pathway lesion. There's a right Wallenberg, lateral medullary syndrome. All of a sudden, the utricle pathway on the right side is down, which leads the brain to believe that the head is actually tilting to the left because there's relative hyperactivity on the left side. So if the brain thinks that you're tilting your head to the left, it's going to try to get back to gravitational vertical, but it's already in the center. So instead of going to the correct side, it's going to overcorrect, and the head's going to go toward the perceived Earth vertical, which is to the right. So this is sort of an attempt of the brain to compensate, but it's not doing a very good job. This is a pathologic response. So what about your patient with the acute vestibular syndrome? This is where the HINTS exam really shines. HINTS exam stands for head impulse nystagmus test of skew. I'm not going to go into each individual component of it. But what does this look like? We're just simply performing cover uncover, alternate cover test on this patient who has spontaneous nystagmus and ongoing vertigo. And clearly this is not a skew. This is just a small horizontal foria that means absolutely nothing in the setting of the HINTS exam, in the setting of the acute vestibular syndrome. This works quite well. Also using a spoon I found to be very effective. You can even check temperature sense on the face and on the arms and legs with the spoon. So it's a handy tool in the virtual world. All right, so clearly this patient has a big vertical ocular misalignment. And when the patient has ongoing dizziness or vertigo, this is a skew until proven otherwise. It is theoretically possible, as you know, for somebody to have an unrelated congenital fourth neuropalsy or a new acquired fourth plus dizziness or vertigo. It's just a lot harder to do. It's a lot easier for somebody to have a skew in association with dizziness and vertigo. So what about fundus torsion? So this is an unfortunate 6-year-old kid who had a stroke involving the left interstitial nucleus of Cajal. This is part of the utricle ocular motor pathway here. And so what happens is that this initiated a pathologic ocular tilt reaction. In this situation, there was a big skew deviation. The left eye was high. There was a right head tilt. And there was this ocular counterroll. So encycloduction in the hypertropic eye with additional excycloduction in the lower eye. So the ocular counterroll, so this is often seen with a skew, a head tilt, and this is the triad that makes up the ocular tilt reaction, as well as an SVV tilt, subjective visual vertical, which we're going to talk about. Almost done. Thanks for your patience. So the bucket test, I suspect that at least some of you haven't heard of the bucket test. The bucket test is evaluating the patient's perception of vertical So you're putting the patient's head into this bucket, which costs less than $5 American to make. If anybody's interested in making it, I can send you a little PDF from the University of Pittsburgh. But essentially, you're putting the patient's head in the bucket. You're holding the bucket, so there are no proprioceptive cues. The patient has no visual cues because the head is in the bucket, and you're asking them to align this vertical line straight up and down to what they perceive as vertical. And you can compare that on the back with this protractor and this weighted string to what earth vertical is. And you can say that this patient has an SVV tilt of 10 degrees to the right or 10 degrees to the left. This is an easy bedside measurement of the SVV, the subjective visual vertical. And let's bring these concepts together. This is a patient who has a big right head tilt, a big left hypertropia due to a skew. He has an ocular counterroll in the expected direction toward the right ear. I asked him if he had taken any pictures recently, and he had. And this is an example of his impaired vertical perception of what kind of earth vertical is. So this is a tilted door, and this is a representation of his tilted SVV, his tilted perception of what earth vertical is. So if you put this patient's head in the bucket, he felt that it was straight up and down when it was really tilted significantly to the right side. This is a rightward SVV tilt from the patient's perspective. And think of the SVV as a perceptual consequence of the OTR, the ocular tilt reaction. It's really abnormal with central lesions, brainstem lesions, but also with unilateral vestibular loss. It's abnormal, but not to the same degree. All right, so patient comes in with BPPV. This isn't something that is such a common complaint to the neuro-ophthalmologist, but it can be. But if you see this upbeat torsional nystagmus with a latency of a couple seconds after the Dix-Hallpike maneuver, this crescendo, decrescendo, this is always peripheral. This is always posterior canal BPPV. This can be done virtually, relatively easily as well. I won't make you watch that. Another nice thing to do in the clinic is if you just simply put the patient's head down between the legs. This is sort of a pseudo-prone position. Oftentimes, if they have a cerebellar cause, if they have a cerebellar involvement, then you'll see downbeat nystagmus when you put the head between the legs, as the patient I saw in clinic just a couple weeks ago. And if you put that same patient into a left Dix-Hallpike or a left roll position, so the patient's lying down and the head is 90 degrees to the left, you'll see a right beating nystagmus. So beating up towards the sky, that's called apogeotropic. And if you turn it in the other direction, now this is a right Dix-Hallpike or a right supine roll test. Now it's left beating, again, beating towards the sky, apogeotropic. These are oftentimes central signs. These are things that you can easily do in the clinic, especially sort of the head between the legs. It can be a little challenging to see the patient's eyes when they're in that position. But if you're able to do that or have a pair of goggles with video screen, for instance, it can be really helpful and handy in teasing out whether this patient could be suffering from a cerebellar cause of their symptoms or not. I'm done. Take-home points. So the ocular motor examination is really important, can't be overlooked, but you have to check all classes of eye movements in all planes, so horizontally and vertically. If you understand the neuroanatomy, you can really localize exquisitely. And this gives you pretty significant clues to the etiology in many cases as well. Remove fixation when possible to accentuate the vestibular nystagmus, whether that's a pen light cover test, even putting a 20 diopter lens over one of the eyes is pretty similar to your Frenzel goggles, quick and easy. With a good history, ocular motor exam, vestibular exam, the diagnosis can almost always be made, even when you're dealing with a vestibular problem. The lab testing is really confirming the diagnosis and your clinical thoughts at the bedside. So thank you for your time and attention. It's an honor to be here. All of the videos that I showed and many more can be found in my collection through the North American Neuro-Ophthalmology Society. Here's my email address. I'm sorry I have to leave, but if you have any questions or comments or concerns, don't hesitate to shoot me an email. I'm happy to help. Thank you so much.
Thank you, Dan. That was wonderful.
Thank you, Dan. That was phenomenal. It was an excellent explanation of a lot of examination techniques and, of course, parts of the oculomotor neuro-ophthalmic exam that I'm sure all of us find a little catchy and difficult. So it was fantastic. Thank you very much for joining us on Thanksgiving weekend, and happy Thanksgiving. And thank you very much. I'm sure questions, if there are any, we'll email to you, and we'll have you again so that we can sort out some of those doubts that we have. Thank you, Dan.
Sounds good. Thanks so much. Don't hesitate to email me. It's a tough topic, but these vestibular dizzy patients will find you, as you know.
Dan,
absolutely.
Top was really gold. True to your name.
Thank you. I appreciate that. All right. Take care.
I just want to make a comment here. I had an interesting case in which a patient presented with loss of saccades to one side. And keeping that in mind, we're looking at a lesion going up to affecting the saccadic lesion and looking something at the superior colliculus or the frontal lobe. But interestingly, what the patient had is a neurocysticercosis at the sixth nerve nuclei, which actually did not cause any motility restriction, but had a huge edema all around it that was affecting the connections coming from the superior colliculus. So interestingly, like once you know the motility issues, you can really find out what the causes and beat the etiology. So especially in a South Indian scenario, we see a lot of patients with neurocysticercosis, so that actually helped clinch a diagnosis. But like the ability not to initiate saccades and normal motility helped us diagnose that it is the connections coming from the superior colliculus which actually affected, not the dormant neurocystic cyst which is there at the sixth nerve.
Absolutely. In fact, the key reason why you need to be able to localize, which is of course Sachin's next talk, is to be able to give directed investigations. We've had a lot of patients whom you can localize onto the brainstem, but they get a screening CT scan done, which may often miss, brainstem lesions, and they may not be visualized because the radiologist is not aware of exact localization of the disease. So a screening CT comes normal, and then you're really struggling and then whenever we try to interpret or understand these patients, we need to get an imaging done. And again, you need to localize, you need to tell the investigator, the radiologist, where exactly you expect the lesion to be so that they can, do more finer investigations. So
Can I ask one thing? Can I ask one thing? What was the status of seventh nerve? Because you said it's a sixth nucleus. So the seventh winds around.
Actually, interestingly, the patient came with 1 day history. He just came suddenly the next morning. He was not able to see. The cyst was very small, just at the level of the sixth nerve, without involving the facial colliculus all around. But as Rohit, I just wanted to make that we have to talk to the radiologist. Sometimes write down what we are expecting, what we want them, so then it becomes easier for them to look. Otherwise, they would just do a routine, So talking to them, coordinating them with them is, I think, very important.
Yeah, we had a similar patient, but obviously, I mean, the little bit of facial involvement was there. So, and of course, there was sixth nerve involvement probably. But we were able to clinically diagnose it by doing a VOR. The VOR was absent. So we thought maybe it's a nuclear lesion. And absolutely, when we did the MRI and had the neurologist inside, I mean, it was actually something, the hemorrhage around there, a nuclear lesion. So VOR is helpful in these situations.
So any other comments or? So maybe we'll take some of the questions and discussions later. And it's a pleasure to now have Dr. Sachin Kedar talk about localizing lesions with oculomotor limitations. And he is a professor of neurological sciences, ophthalmology, and visual sciences. And he's the program director of the residency program. And of course, he's an old friend who has frequently come and helped us run the neuro-ophthalmology clinic, neuro-ophthalmology conferences, the INOS. He's, as I said, the program director of neurology at the University of Nebraska, and an outstanding teacher with really great clinical skills and clarity of thought. So a pleasure to introduce and have Dr. Sachin talk on disorders of ocular motility and kind of localizing them. Sachin.
Thank you, Rohit. Can you hear me?
Yeah, go ahead.
Wonderful. Well, it's a pleasure to be here today. Good evening to everybody in India and good morning to those of us joining from elsewhere. I guess, Rohit, you gave me a very choice position between Dan Gold on one side and Dr. Sharma on the other side. So I guess my job is now really cut out for me. Ironically, it's exactly 1 year since I was last in New Delhi for the INOS conference. And as I was telling earlier, I hope that this pandemic ends soon and next year we'll get to meet each other in person. But today I'll be talking about disorders of ocular motility using a case-based approach and how to localize the lesions. So start off with a basic question. Why do we have this intricate pattern of eye movements? And the answer is really because we want to achieve fixation. And once the fixation is achieved, you want to maintain it such that your visual acuity is the best possible. And you want to avoid retinal adaptation. So within these constraints, we know that the best visual acuity happens when the object of regard falls in the fovea. And as we move away from the fovea, the visual acuity reduces quite dramatically, so that by about 2 degrees from fovea, your visual acuity has already dropped about 50% of what it should be. So just to revise what we learned from Dan Gold's talk, there are broadly speaking 6 categories of eye movements which we should all examine when we are examining the oculomotor system. The first 4 of these help us achieve or maintain fixation. So the visual fixation maintains fixation of a stationary object without a retinal adaptation, eliminating our vision. Vestibular response maintains fixation during brief head rotations or translations. Optokinetic response maintains fixation during sustained head rotations or translations, such as the video that Dan Gold showed us when the girl was traveling in a train. Smooth pursuit helps us maintain fixation of a small moving target. The last 2 helps us achieve fixation of new objects. The saccade brings the images of new objects to the fovea, and the Convergence brings images which are new at varying distances from the eye. The Convergence eye movements are the only form of disconjugate eye movements in this categorization. Now here is a basic circuitry for what we know as a saccadic system, but in general, it applies to all categories of eye movements except the ones that are a reflex. The planning for the eye movements takes place in the cortex, the frontal cortex and the parietal cortex, and you can see the specific areas that are involved with ocular motility. Now you can consider this to be analogous to all other movements that the human body takes up, such as the motor movements, and the circuitry is about the same. Once the planning takes place in the frontal cortices, the signals undergo a lot of modulation in what we know as the basal ganglia before the signals are transmitted to the superior colliculus, which, as you might know, forms a sort of a gatekeeper to the saccadic system. Once the signals are modulated, they are sent to the brainstem saccade generator after being optimized by the cerebellum. And from here, the pulse and the step signals are generated and passed on to the nuclear and the intranuclear pathways by which the eyes can move. So this is a slide that is courtesy of David Newman-Toker and Dan Gold. And simplistically speaking, you can divide the brainstem into 3 regions. And the machinery for enacting the vertical eye movements are located in the midbrain, the horizontal eye movements in the pons, and the medulla holds the integrator circuits primarily for horizontal eye movements as well as the vestibular nucleus. This is the intranuclear pathway, which is responsible for moving the eyes, and we are all very familiar with it. And I will not spend too much time going over this, but you can see the subarachnoid course of the 3rd, 4th, and the 6th cranial nerves as it enters the orbit through the superior orbital fissure after traversing the cavernous sinus before it innervates the 6 extraocular muscles. Now, to understand why we need this sort of a machinery, you have to understand how the eye moves. Now, the eyeball is suspended within the orbit in the midst of orbital fat and other connective tissue, and are suspended by muscles, tendons, and ligaments. And as a result, there's a lot of resistance to movement. So when the eyeball is at rest, to be able to move it to an eccentric position, you need a high frequency neural burst called the pulse command so that the eye can move from rest to an external position. And you can think of it like the Newton's first law. Now, once the eyeball moves into the eccentric position, it has to stay there and not drift back towards its center because of the forces of elasticity. So remember, you have all of these connective tissue within the orbit that will try to bring the eyeball back to the position of rest. And to achieve this, you have to have another sustained neural activity called the step command. So how does the neurological system achieve this? So the pulse signals are generated such that they are velocity encoded, and the step position commands are then generated by mathematical integration of velocity by time to achieve the position command. And this is done by what's known as the common neural integrator circuits. So here is how the horizontal gaze works. So the paramedian pontine reticular formation is the one where the pulse commands are generated. These commands are then transmitted to the sixth nerve nucleus, which acts as a horizontal gaze center. As you know, the sixth nerve nucleus will supply the motor neurons to the ipsilateral lateral rectus and will send interneurons to the contralateral third nerve nucleus through the medial longitudinal fasciculus. Now, the horizontal gaze integrator circuits involve the medial vestibular nucleus and the nucleus of prepositus hypoglossy. And these are involved with all sorts of horizontal movements. So if there's a lesion affecting this circuit, all horizontal movements will be affected. There is an analogous circuit for vertical gaze control. And this is located primarily within the midbrain, and it comprises of the rostral interstitial nucleus of the MLF, which generates the pulse command to move the eyes up or down, and the interstitial nucleus of Cajal, which holds the eyes in these eccentric positions. And it also acts as the vertical integrator circuit. And as we know, the nucleus which subserve the vertical eye movements or the cyclovertical movements are the third nerve nucleus and the fourth nerve nucleus. There is extensive decussation across the posterior commissure. So to eliminate vertical eye movements, you essentially need lesions to affect the bilateral nuclei. So how do patients with ocular motility disorders present? Now, they commonly present with symptoms of ptosis, diplopia, or oscillopsia, as you saw from Dan Gold's presentation. They may also present as part of the orbital syndrome with other orbital signs such as proptosis or exophthalmos. They can form a part of other neurological syndromes, as we know from the various forms of the brainstem syndromes. But they will also present to the family doctor, to the ophthalmologist, to the optometrist because of the impact it has on daily activities. So some of these subtle signs include difficulty reading, difficulty driving, unable to ambulate, unable to do near work. Or they may sometimes present with very unexplained visual difficulties, which are intermittent, maybe with depth perception problems, or maybe with intermittent symptoms of diplopia or oscillopsia. And in these situations, going through the entire oculomotor system is always helpful to localize the lesion. So now let's switch gear to a few cases by which we can approach a patient with ocular motility disorder. So let's start with case one. This is a 66-year-old who presents with a 2-week history of complete ptosis of the right eye. About 2 weeks prior to presentation, he had noted intermittent double vision. He describes a pressure-like sensation behind the right eye, but doesn't really complain of a headache. There's a history of hypertension and diabetes, but these are well controlled. On examination, he has normal visual functions, which means visual acuity, color vision, visual field when tested individually in each eye. There is no proptosis, but examination reveals that there's an absent corneal reflex on the right side, as well as right V1 anesthesia. The neurological examination is normal. So the pertinent abnormalities are shown here. You can see the right eye is in a down and out position. The pupils are mid-dilated and fixed. The eye is able to abduct, but is unable to elevate, depress, or adduct, and there is intact intorsion. So here we have somebody with a right pupil involving oculomotor nerve palsy, along with a right V1 ophthalmic nerve involvement. And so you're now talking about a polyneuropathy of the cranial system. And so from our knowledge of neuroanatomy, we know that the lesion has to lie somewhere in the cavernous sinus or the superior orbital fissure, because that's where your oculomotor nerve and the ophthalmic division of trigeminal will come close together. And so now that we know where the lesion is, the question is, what is it? So this is a subacute presentation, and now you're worried about a compressive infiltrative kind of a lesion in this location. There's no choice but to do an imaging study of the brain and the orbits. And here you can see a large homogeneously enhancing mass in the middle cranial fossa, originating probably from the meninges of the sphenoid bone, involving the superior orbital fissure and the cavernous sinus, probably compressing the third nerve and the fifth nerve. So this turned out to be a meningioma. So the patient underwent a craniotomy with subtotal resection followed by radiation therapy. 6 months later, there was 70% improvement of ptosis and ocular motility. And at this time, the patient had no diplopia in primary gaze. He was not interested in any surgical correction of the remaining ptosis or of his ocular motility, and he continues to follow up with us. So as you can see, a knowledge of neuroanatomy along with pertinent examination help us to differentiate between what appeared to be a pupil involving third nerve palsy instead of a combined third, fifth nerve involvement. Moving on to case 2. So this is a 50-year-old patient who presents differently from what we saw in the first patient, but this time she had acute onset of headache, dizziness, somnolence, and difficulty reading. So she had the symptoms going on for about 10 days, and she's a teacher, but she complains that each time she tries to check the grades of her students, she's unable to do that. She has a history of hypertension. She uses phentermine for weight loss. Her examination shows normal visual functions, pupils, and her neurological examination is otherwise normal. So let us look at this video of her eye movements, which are the only ones that have a problem. Okay, so we did a full oculomotor examination in her, but what stands out and what is most striking is the complete vertical gaze palsy. You could see that she could barely initiate some slow, inaccurate vertical up gaze saccades, but she couldn't do pretty much anything else with down gaze saccade. She could not hold that vertical saccade up in that position in superduction. Also, you can notice that she was a little bit slow in following commands. And this is at the time when she was at her perkiest best. Otherwise, she was somnolent and would sleep for many hours during the daytime. So our knowledge of neuroanatomy tells us that a lesion that can cause vertical gaze palsy and is accompanied by somnolence is likely in the paramedian regions of the reticular activating system. So a paramedian pontine or a paramedian midbrain lesion would cause somnolence, but a paramedian midbrain lesion involving bilateral MLF and interstitial nucleus of Cajal would cause vertical gaze palsy. So this is a patient who had been to an ophthalmologist previously, had an MRI, and was then transferred to our system. But now we could, based on neuroanatomy, tell the radiologist where to precisely image the MRI. And now that we know where the lesion was likely to be, a second MRI was obtained with thin sections through the brainstem, and see from the diffusion weighted imaging, there is a paramedian bilateral midbrain infarct extending upwards to the medial thalamus over here. And this is an acute ischemic stroke involving the artery of Percheron, probably because of severe hypertension. So we managed the blood pressure while she was in the hospital. We asked her to stop phentermine, which is a weight loss medication, started her on aspirin. Fortunately, this is a small stroke, and by about 6 weeks when she had returned back to clinic, she was back to baseline. Case number 3. So this is a 52-year-old patient who presents with acute horizontal binocular diplopia and dizziness. She has a history of hypertension and type 2 diabetes. She has normal visual functions, pupils, and a normal neurological examination, with the exception of this. Okay, so hopefully you would all see that she is unable to adduct that right eye, and there is a horizontal jerk nystagmus of the abducting left eye. Vertical is pretty much intact, and this is right internuclear ophthalmoplegia, which will localize the lesion to the right medial longitudinal fasciculus. So going back to the neuroanatomy, we know that the horizontal eye movements are generated through the PPRF and involve the 6th nerve nucleus, which not only help abducting the ipsilateral eye, but will also adduct the contralateral eye by sending interneurons through the contralateral MLF. So we now know that a precisely located lesion in the brainstem, which is paramedian, can produce an internuclear ophthalmoplegia. So if this patient was a young person, say 40 or younger, the number one differential would be a demyelinating lesion such as multiple sclerosis involving the MLF. But in an older patient with multiple risk factors is more likely to be an acute ischemic stroke, less likely to be a space occupying lesion such as from a tumor such as a glioma or from other infectious causes. We just learned about how neurocysticercosis can do the same. But no matter what, the examination points as to where the lesion is likely to be, and you can guide the radiologist to obtain thin sections through the brainstem to identify it. And when thin sections were obtained through the brainstem, you can see a very small punctate ischemic lesion involving the region of the MLF. And this is due to an occlusion of the brainstem perforator vessel. In this patient, once again, the management was that of controlling the blood pressure, diabetes management, and then we started her on an aspirin and statin. And again, like with all perforating lesions of the brainstem, she returned back to baseline very quickly by about 6 weeks, and all that was left at the end was a slightly slowed adducting saccade of the right eye. Case number 4. So this is a 70-year-old retired teacher with a 3-year history of reading difficulty who has been to multiple ophthalmologists and optometrists, also complains of loss of depth perception, increased falls, especially when walking downstairs. But 5 years ago, she was diagnosed with Parkinson's disease, and she has tried bifocals, trifocals, progressives, nothing helps. Ultimately, she had cataract surgery, believing that that would help improve the vision, but she noted that the improvement was transient and mild at best. So her near and distance visual acuity are normal. She has normal color and essentially normal stereo acuity. And the only examination abnormality in slit lamp was moderate dry eye on both sides. So here is her oculomotor examination. So you can see the square wave jerks, which are macro square wave jerks. So you can see multiple problems of the oculomotor system over here. Her fixation is abnormal with macro square wave jerks. You can see the slight lag before she initiates both horizontal and vertical saccades, indicating apraxia. You can see significant impairment of the vertical gaze, both up gaze and down gaze, which she can overcome with vestibular response. You can see that the saccades are slow and probably dysmetric. And an additional problem that she had was significant convergence insufficiency when she's asked to look at a near object. So with these kinds of multiple problems of oculomotor system, how do you localize it? So the fixation errors, the saccadic intrusion, points out to a problem within the modulating system of the basal ganglia, primarily supracolliculus, which acts as a pathway or the gateway to the brainstem saccadic generator. One of the inhibitory impulses into supracolliculus is through the substantia nigra pars reticulata. If you remember, this is the nucleus that's most often affected in Parkinsonian diseases. Saccadic apraxia essentially implies that the signals that are being transmitted to the brainstem generator are not normal and have a significant lag. Most commonly, you can see this in bifrontal or bifrontoparietal lobe lesions, such as in balance, where you have apraxia of eye movements. And of course, this patient has significant up gaze and down gaze palsy and convergence insufficiency, which points out to abnormalities within the upper brainstem mechanisms that relate to vertical gaze. And in a patient with Parkinsonian features, this would be a diagnosis consistent with progressive supranuclear palsy, which is a form of Parkinson's plus disease. Now you may ask, what's to be done with these patients? And the answer is a lot. The management is geared towards safety, improving quality of life and comfort for patient and caregiver. The trick over here as ophthalmologists and neuro-ophthalmologists is to emphasize that the patient should avoid activities that force down gaze as much as possible. So if you recollect, she's a teacher who has to look down as she tries to do her near work. And it is impossible for her to drive her eyes down without actually moving her head into eccentric positions. And when she went to multiple ophthalmologists, each one of them gave her multiple vision glasses, either bifocals, trifocals, or progressives. These are not going to help a patient with a gaze palsy because they cannot maneuver their eyes into a position where these will be helpful. Also remember, when she tries to walk downstairs, she has to look down because her eyes do not automatically move into down gaze. Now, to give you an idea of how important eye movements are in reading, here's a slide that's courtesy of my colleague, Dr. Lau from Stanford University, who uses this reading chart and looks at the eye movements and analyzes how they differ in normal and disease conditions. So here's a normal adult. So you can see the small, accurate, fast saccades as they read the numbers from left to right, okay? Very quick and is completed within 10 to 15 seconds. Now here is a patient with severe Parkinson's disease or Parkinsonian plus disease, and you can see how they struggle. So here they are just trying to initiate the reading process, and you can see the bubble denotes the amount of time that is spent at each location on the chart. And you can see the small regressive saccades backwards. They have difficulty going to the next line. They have difficulty maintaining fixation. They get lost in the page. And when they get lost in the page, they really struggle to recover from there. So you can see the bubbles increasing in size, indicating the amount of time that is spent in each location. So what took a normal person about 10 seconds is now more than a minute for a patient with severe Parkinsonian diseases. So you can see the UPDRS score is 21, and this keeps going on and on. So let me fast forward for you, and you can see ultimately they just give up. So you can imagine the impact this has on their ability to read, and if reading is impacted, one assumes that other forms of near work is also impacted. So how do we help these patients with progressive supranuclear palsy? Well, if they cannot look down, then perhaps you can move objects to the primary gaze. And you can do this by using simple devices like this music stand, on which they can perch their books or whatever else that they want to read. They can use audiobooks if vision is severely affected. Make sure and provide them with single vision glasses. Yes, it's cumbersome to carry a distance correction and a near correction, but that's the one that will provide them with the maximum relief. If they have convergence insufficiency, give them prism correction. Manage their dry eye with frequent artificial tears, lid massage, and dry compresses. And advise them to take frequent breaks when reading. Safety is paramount. If they have multiple stairs at home, ask the family member to help them when they're walking downstairs, or avoid walking downstairs to prevent falls. So in the last couple of minutes, I'm going to go to case 5. This is a 54-year-old patient who has noticed reading difficulty for about 6 months. And when specifically asked what they mean, they say that the lines appear to intermittently split and double vertically. Occasionally when they are reading, they notice that there are gaps between words. This causes them to have to miss their position in a page, causes headache, and frequent blinking is necessary to relieve the headache. The only past medical history that's of pertinence is concussion sustained about 10 years ago. On examination, they have normal visual acuity, color vision, absent stereo acuity. The eye movements are full. There's normal fixation, saccades, pursuits, and VOR. But cover-on-cover test reveals 2 prism diopters of concomitant right hyperphoria and 2 prism diopters of esophoria. And when a visual field was performed, you can see a complete bitemporal heminopia. Now, this seems to be easy. With a bitemporal visual field defect, the lesion is probably in the area of the optic chiasm. And indeed, when an MRI of the brain is performed, you can see a large pituitary adenoma, which is compressing the optic chiasm from the inferior part of the chiasm. And that's the reason why you have the bitemporal heminopsia. But then why do they have the double vision? And the answer is something called a Hemifield slide phenomenon. And you're unlikely to have a patient describe this to you unless you specifically ask them about problems with reading and near work. So what is a Hemifield slide phenomenon? So we have the right half of a visual space and the left half of a visual space, which is represented in the opposite hemispheres of the brain. And the information for each half of the visual space is carried by both eyes. So the right visual space is represented by the nasal retina of the right eye and the temporal retina of the left eye. And so there is an overlap between the visual fields of the right eye and the left eye, and this is what helps fusion of the two eyes. So what happens in bitemporal heminopia? In bitemporal heminopia, you lose the decussating nasal fibers in both eyes, and as a result, the 2 remaining nasal halves are completely unilateral, which means the right nasal field is represented by the left eye and the left nasal field is represented by the right eye. And so there is no overlap of the visual fields. And as a result of the loss of overlap, you now have break of fusion, and any previously compensated strabismus now becomes manifest, even if it is a very small strabismus. So in our patient, he had a hypertrophy of the right eye, and as a result, the 2 hemifields will slide against each other vertically. And so one of the hemifields will slide up, which is the left eye, and the right eye will slide down, and you can see the lines vertically separated. He also had esophoria, which became atropia when the fusion was lost, and the 2 hemifields would slide away from each other, leaving a gap right down in the middle over here. So this patient underwent surgical resection of the pituitary macroadenoma with significant improvement. At 1 month. There was residual bitemporal heminopia, which is partial. And this was almost completely resolved by about 10 months. And he noticed improvement of his reading and near work, and his stereo acuity was normal. So to summarize, disorders of ocular motility and alignment can occur in lesions anywhere along the cranial neuroaxis. The localization of the lesions is a first step in accurate treatment and effective management of the underlying disease condition. And the only way you can do that is to know the basic machinery that drives these eye movements, and when they are abnormal, how we can localize it to different parts of the brain. Remember, some of the lesions are very small, but they involve parts of the brain with high, as we call it, real estate values, such as the brainstem, where even a tiny lesion can produce significant difficulties. So I leave you with this website. If you have not already been here, it's the Novel website, and you will find a lot of resources, including Dan Gold's collection of ocular motility disorder. As chair of the NANOS curriculum committee, I look at most of these collections and use them for various educational materials that NANOS produces. So thank you, and if you have any questions, I will be happy to take them.
So thank you, Sachin. An excellent presentation. Would we have any questions or discussions?
I think,
any comments from our panelists? Meanwhile, I'll request Dr. Swati to see if there are any questions in the chat box.
Yeah, Dr. Sachin, that was an excellent presentation. How many times have you seen a patient with internuclear ophthalmoplegia have you can say, an exo in the primary position?
An exo in the primary position, it depends on the setting. So when I see them acutely, which means within a few days, a few hours of onset, it's almost always. If I see them a few weeks later, which means they've been to multiple other places and then come back in a few weeks, very uncommon.
So is it in the involved eye or is it in the abducting eye? The one with the nystagmus?
The nystagmus is the abducting eye. So when you're trying, because it's a contralateral to the horizontal gaze center. So it's the interneuron that's getting affected. So the eye that is abducting is essentially normal, but the eye that is adducting cannot do that. And the feedback mechanisms for holding the gaze is also not working. And that leads to the abducting saccade as the eye, as the circuit tries to correct for this discrepancy.
Okay, thank you.
Dr. Sachin, I have a question. Is there a difference? There is an entity called the pseudo-internuclear ophthalmoplegia in myasthenia. And can we say that we can differentiate this by the absence of abducting nystagmus in myasthenia? Is it always true, or there is no real difference in both these conditions?
I was going to show you that as another video with a 26-year-old patient who came to me with right INO and came to me 6 months later with a left INO. It was an exact mimic of INO with the abducting nystagmus. It was so perfect that I got 2 MRIs of the brain, both of which were normal. I was convinced that she had multiple sclerosis. And after 3 months, she had ptosis of one eye. And that is when the investigations for the other side of the visual pathway, which is by the neuromuscular junction, revealed that she had myasthenia gravis. So the answer is, I don't think I can, label it one way or the other just on the basis of the abducting eye nystagmus. I have seen it, yes.
Thank you. Thank you.
Doctor, I have a question for Dr. Sachin and the other panelists. The patient where you had the PSP and you gave all the treatment options. Do you think that uniocular occlusion would work well in those patients? Particularly when they're going down the stairs or where they want to read, you could patch one eye and then continue. Would that be a lot more easier if the prisms and the other things don't suit them?
So the prism is only for convergence. So if they have convergence insufficiency, you give base out prisms and that'll help them with convergence only. Vertical prisms will not help these patients. Uniocular occlusion is again to get rid of diplopia for near work. But
right. The other reason I was suggesting uniocular occlusion is because convergence is a binocular phenomenon. So if you cover one eye, would that make reading more easy for them?
If convergence insufficiency is the primary problem, yes. But the problem with these patients is unless you hold the book up, they cannot read. They cannot get their eyes into a down gaze. So the down gaze seems to be the problem. The book up by using the music stand, and if they still have difficulty reading because of convergence insufficiency, I almost always ask them to occlude one eye. Again, the risk you have to always consider in these patients is falls. They are at a very high risk for falls. And I'm always hesitant to give these patients prism except when they're sitting, because you're introducing another component which increases their fall risk.
Dr. Ambika had a question. Dr. Ambika is head of neuro-ophthalmology at the Shankar Nethralaya, Chennai.
Hi.
Ambika.
Hi, Sachin. Great talk it was. Hi. I just have a doubt. Do you get to see this Hemifield slide phenomenon even after those cellular masses post-surgically when they come back with a chiasmal prolapse? And sometimes we see these bitemporal effects persisting. And would you see a hemifield even after a chiasmal prolapse?
So the Hemifield slide phenomenon, I don't see it in every patient. And I think it boils down to a combination of, is there a complete disconnect between the right and the left eye preserved hemifield? So if there is any preserved visual field left of the temporal regions, then you have fusion. And once they have fusion, it goes away. Number two is if they don't have fovea to begin with, you don't see it. Now, your question about do we see it with the prolapsed chiasm? I don't know the answer to that. I have personally not seen it, but that may be because my patients do not fit into those groups. So it's not very common. You know, if I say in 100 patients with pituitary adenoma, I may see this in about 5 or 6, and that's because I specifically ask them when they come in and have them read when they're in my clinic.
Exactly, because we came across, a couple of times this problem when a patient came with a post-surgical sudden worsening of visual fields, and the patient complained of diplopia. And yes, as you said, the patient did not have when the patient had a cellular mass, but she had it after the surgery, and she had it, and that was the diagnosis by the radiologist when we picked the chiasmal prolapse causing dense defects. And we were debating whether it's a residual mass which is sticking around or it's the prolapse which is causing this field loss and the diplopia. That's the reason I brought it up, and I was keen to know what is your opinion on that.
Sachin, how would you recommend managing? Do you think that if they have, would they be better off if there's an esotropia? I mean, like suppose they come with a strabismus and post their surgical resection, the diplopia persists. So would you feel that you would prefer of having them slightly esotropic so that they don't have overlap fields, but then that scotoma in the middle can be fairly discomforting? Or I mean, if they are even slightly exotropic, then they have an overlap and they have a diplopia. So
there is no good answer to that question, Rohit, because I've seen patients with both problems having significant complaints, and it also depends upon their occupation. If they're doing a lot of reading, for example, if they are, say, lawyers, one of the patient was a lawyer, then it slows down their reading to such an extent that they have to quit their job. I don't know. I've not tried Prism. I don't know if it works or not in these patients. I don't know if strabismus surgery is the way to go. But usually what I have done is send them for, this is one of the indications for surgical corrections. They have a pituitary adenoma and a diplopia. We talk about field defects. We talk about, antivisual pathway compression, but diplopia is also another one of those. And so any improvement of the temporal visual field, even if it is partial, will immediately cause them to achieve fusion.
Right.
So that's where I am, but I don't know the answer to whether prisms or surgical corrections are going to help them. All three forms of misalignment is very disabling.
Thank you, Sachin.
True.
Yeah, I agree with that. I mean, of course, you increase that field of vision, probably, yes, the double vision would reduce. And I think there have been few reports where this phenomena has been corrected by strabismus surgery, but then other issues crop up, like some missing of words or images in between. Right. So these issues are always there. I mean, a perfect correction may not be possible with them.
Right. So we've had issues when we've managed a couple of these patients, and as Sachin said, I mean, sometimes it's better to wait and hope that their field improves post surgery and over time as it improves neurologically, and they may be able to have a little bit of overlap that will correct the diplopia that they're having, and the phoria, the presented squint becomes a phoria again. So excellent. I think we'll go on to our next talk, which is on the management of ocular dysmotility, and that would be given by none other than Professor Pradeep Sharma, who is the head of pediatric ophthalmology, strabismus and neuro-ophthalmology at RP Center, AIMS, New Delhi. And of course, is an outstanding speaker with great experience in managing all kinds of ocular dysmotility, particularly expertise in paralytic squint. So, Professor Pradeep Sharma.
Thank you, Rohit. Am I audible?
Yeah. Yes, sir. Please go ahead.
So it's a really interesting evening that we are having here. And after the wonderful talk by Dr. Daniel Gold on examination and the localizations done by Dr. Sachin, I think most of the cases which are problematic would have been sifted or sent by Dr. Sachin to the neurologists or the neurosurgeons. And what is left over for the ophthalmologist to manage is probably what is in my kitty. But ocular dysmotility by itself is a very complex term. It covers so much that probably we cannot cover in this much time. It may be a neurogenic, supranuclear, nuclear or infranuclear pathology. It may be the CCDDs now that they're also neurological and now earlier known as restrictive strabismus. It may be myogenic, including myasthenia or myopathies that we deal with as chronic progressive external ophthalmoplegias. Or it may be restrictive conditions like thyroid, pseudotumors, post-strabismus surgeries that will cause dysmotility. Nystagmus, of course, is a problem. And again, when it is infantile versus acquired, the management would differ. Many nystagmoid movements come into our purview in the form of the convergence retraction nystagmus, the supraoblique myochemias, or ocular masticatory myarrhythmias. This is nice video just to show how the complexities can be there. This is a case of a bilateral internuclear ophthalmoplegia. Sorry. Bilateral, is it coming?
Yes.
Yeah. So this is a bilateral adduction deficit, you can see, abduction nystagmus, but a normal convergence. I think. But there were also vertical nystagmus also. I think it can be as complex or even more when there is a combination of these. Just to see how we manage. Many things have been talked about, but just a simple generalization, I would like to say, never forget to look for the fields and the fundus which may be there.
Management in the third nerve pulse is then.
Management, you have to take care and you need to investigate. I think that needs to be highlighted. It may be the causes which may be underlying. It may be a tumor or trauma or aneurysm. Usually, when it comes to the ophthalmologist, we have to observe 2 monthly for a 6 month, 9 months, or sometimes even up to 12 months to see that the recovery happens. Non-surgical management in the form of Botox may be used in the intervening periods in order to expedite the recovery. Techniques like using glasses with crutches for ptosis, prisms, as Dr. Sachin was talking about, or even the contact lenses. But finally, it comes to the surgery. And these may be the different situations. In the non-surgical management, again, we have the options of pharmacological treatment in the form of pyridostigmine or steroids, like in myasthenia, especially ocular myasthenia gravis, baclofen in cases of periodic alternating nystagmus, especially the acquired type. The supraoblique myochemias also it may be used. Carbamazepine, phenytoin, gabapentin, memantine, these are again drugs which may be used in supraoblique myochemias. And then topical betaxolol, again used in supraoblique myokemia, and brinzolamide nowadays in some nystagmus. Optical treatment in the form of glasses, as we have talked about, maybe there, Botox also. And there are other extraneous situations like the transcranial magnetic stimulation, the transcutaneous neurostimulation or acupunctures, which are all there to confuse us. But important thing is that we may have to do timely realignment, even in adults. It has been seen in studies that macular binocular vision becomes susceptible if it is a problem, a constant misalignment more than 6 months or a year. So if a situation is that there is a residual squint, which is crossing the midline, of course, we can do a recession resection or a recession plication. But here comes the problem sometimes, as we were talking about a situation of having a bitemporal hemianopia, as Dr. Sachin was talking about. This was a 32-year-old male. Vision in the right eye was 612, 6 in the other eye. The road traffic accident 5 to 6 years back. So it was not an adenoma which could have been treated. It was a permanent loss for the optic chiasma, and it led to an bitemporal hemianopia. But he also had a sixth nerve palsy with an esotropia of 35 prism diopters, and he was bothered and he wanted the correction. But when we saw that there was a bitemporal hemianopia, as Dr. Rohit was pointing, there is a problem that if you slightly overcorrect even, they would have a diplopia. So what did we do? We tried to do application of 8 mm and then left middle rectus recession, but we fortunately kept it on an adjustable suture, which was in this case initially 6 mm, but we realized that he had a problem, the diplopia and the Hemifield slide problem. And we had to keep on adjusting till about 3.5 millimeter recession. And finally, he was in a position that he had the ESO corrected and also the diplopia resolved. So in such situations, using an adjustable suture while doing a squint surgery is a real blessing. Strengthening procedures nowadays we are talking about, and we again switch to plication rather than resections as far as possible, especially in the paralytic squints. When we are dealing with the third muscle, it's better to do application and saving the entry segment vasculature. I think I would not go into the videos because the time lag. But when the situation is that the eye doesn't cross the midline, then we have to resort to doing a transposition procedure. Like in this girl, you have an abduction deficit, the eye doesn't cross the midline. And as we know the algorithm for transposition, if the eye is not crossing the midline, we look for the saccadic velocities, and we find that there is a saccadic velocity not good enough, it's poorer than 100 degrees per second, then we have to do a transposition. And the transposition has evolved over the ages. It was Hammersheim's or O'Connor's procedures or Jensen's procedure in the past. Nowadays, we have better techniques to handle these problematic cases. It was augmentation by posterior fixation suture in '97 for full tendon VRT, which was suggested by Scott Foster, and it definitely gave us much more abduction in these cases. But since a full tendon VRT has a risk of entry segment ischemia, because both the verticals are very important for the vascular supply, Rosenbaum's group suggested using a partial VRT with a posterior fixation augmentation. And this is what is many a times done by people. And as you see here, the Hammersheim's is done with an augmentation of the vertical torque by putting the posterior fixation sutures 8 millimeters away from the insertion. Now this girl, we did the same, and she was very happy. The head posture got corrected. The esotropia in the primary position is good, and the abduction has improved. But every time you may not be lucky, because there is a non-adjustable character of these Foster sutures. They cannot be adjusted. And if you have under or over correction, the patient may not be happy. And especially when there is an over correction, it is very, very disabling to the person. And like in this case, he was not happy because, and then we had to undo part of the surgery. Then comes the role of having an adjustable VRT, a partial or a full thickness VRT with cross action. Now, this is the technique which was popularized by Guyton when he used both the superior and the inferior recti on full width transfer, but cross-acting. And so he could do it on an adjustable suture and giving rise to a better control. He modified this technique a little bit using a partial VRT and still having a cross-section so that we could get the advantages of both. The entry segment ischemia was also prevented because the partial blood supply being saved, and we have the cross-section sutures which are on the adjustable sutures, and we can give a more predictable outcome. Again, the videos I will just skip here. So adjustable cross-section partial VRT in the lateral rectus pulse is something that will help us in correcting the ESO in the primary position, as well as improving the abduction. And especially if there are additional problems, like we saw that case which had a homonymous hemianopia or a bitemporal hemianopia, when it's more critical to have the adjustment, these cases are of great help. Sometimes we have cases in which we have to undo the surgery or re-surgery. Adjustables will help. There are several procedures which have been described, and I would say that it's like the dinner plate. We have so many options. We have the partial tendon VRT, we have the full tendon VRT, we have single muscles being used for transposition, SRT or the IRT, superior rectus or inferior rectus transposition. We can further advance the effect augment the effect by resecting the transposed muscle, augmenting by Foster sutures, as we had talked about, or augmenting by cross-section, which gives us the advantage of adjustment. We can also do an additional effect of the antagonist muscle on a recession, or if you want to save the intersegment supply, then you can put just a Botox injection instead of recession, or even an LR plication may be used for augmentation. But the dinner plate is not complete. We still have the dessert, that is the Nishidas, which is modified Nishidas procedure. Here the advantage is there is no disinsertion, no splitting, and so no risk of intersegment ischemia. We are directly vectorizing the force to the sclera. It's like the direct bank transfer, rather than having the bad or lax middleman, which will be the paralyzed muscle as in Jensen. So I would never advocate a Jensen's procedure. And we have now the modified Nishidas, which gives us much more better results. But mind you, it is not an adjustable procedure. And whenever we have this, we may have to put the medial rectus on an adjustment in order to get a more predictable result. Like in this case, in which Nishidas has been done along with an MR on an adjustable suture. So VRTs for abducens palsy, the choices would fall on adjustable cross-section partial VRT on one side, and the other thing which we may use is modified Nishida and with an adjustable MR recession. Both the things are good options for 6 nerve palsies in which the eye doesn't cross the midline. But sometimes you may have to do a combination of both. And if suppose you have a slip, or sometimes that like this case which has been presented in JPOS by Yao, in which he did a Nishida on the inferior rectus and a full tendon SRT on the superior rectus. Coming to the superior oblique palsies, we are all aware that we need to diagnose them by a proper thing, but also look into the fundus to look for the extortion, which may lead you towards that. How do we manage these cases? You have to look for the hypertropia in the primary position and also in the different gaze positions as per the NAPS classification. Second thing is notice how much is the hypertropia in the primary position. If it is more than 20% diopters, so single muscle surgery will not be effective, and you may have to add on to the second muscle. Versions, especially the inferior oblique overaction, is there and how good or bad it is. Superior rectus contracture should be looked for by looking for the FDT on the superior rectus. If there is one, it may lead to a double depressor underaction, and we may have to do a superior rectus recession on the ipsilateral side. Superior oblique tendon laxity or the absence, sometimes we can find out, and we'll do an intraoperative FDT. Recently, we had a case in which we thought we will do the tucking, but we found the superior oblique was missing and we had to do something else. Torsion, mainly with the little vertical deviation, is in cases of bilateral superior oblique palsy. So the choices would fall on the inferior oblique weakening procedures, mostly recession, sometimes anterior positioning, and for severe ones, we use the anterior nasal transpositioning. Superior oblique tucking, whenever it is superior oblique is lax and is available, it can be done. Superior rectus recessions, if SR FDT is positive. A contralateral inferior rectus recession is another option, but to my mind, it is usually a later option. I would rather prefer to do an ipsilateral surgery. And finally, the modified Harada-Ito procedures if you have a bilateral superior oblique palsy. So these are the several choices that we have for the inferior oblique weakening, and we can get a very predictable result. And for a very strong 3+ or 4+ inferior oblique overaction, we now have the choice of doing the anterior nasal transposition. But as I said, bilateral superior oblique palsy you have to keep in mind, especially if it's a case of a closed head trauma, subjective complaints of torsion, more specifically extorsion, objective torsion more than 10 degrees, alternating hypertropia, as you can see here in the picture, both the sides when the head is tilted, the eye is, little eye is upshooting. So this is indicating that there is a bilateral superior oblique palsy. And you will notice that instead of a head tilt to one side, usually these people will have a chin down position. It's like a bull raging against you. A V pattern esotropia is the reason for this, because in the down gaze there is an eso, and in the up gaze it becomes ortho. A chin down head posture should be there if there is a bilateral superior oblique palsy. Coming to the third nerve palsies finally, again if the eye is crossing the midline, you have a choice of doing a resect or a recess and plication procedure. But if the eye doesn't cross the midline, we have very few options for third nerve pulses, as the vertical recti are not available for transposing. So we may have a very tight lateral rectus in which we have to do supramaximal lateral rectus recessions, but sometimes even that is not enough. So a periosteal anchoring of the lateral rectus can be done to take away the lateral rectus altogether and put the medial rectus on a periosteal so that we can have maximal leash effect on the MR. Sometimes we have used even bupivacaine to inject into the muscle in order to induce a little bit of fibrosis, which may help us in retaining the effect of eye remaining in that position. Another option which is nowadays available is the split lateral rectus, a Y-split lateral rectus transposed to the medial side, and it gives us very good results. But we have to be very careful when we are splitting. We need to split it as much as 20 to 25 millimeters. Otherwise, you may have, and even some cases, in spite of a good surgery, you may have the effusion syndrome, the choroidal effusion syndrome, or even the vortex veins being compromised. Finally, if you have a situation in which it's 80 or 90 prisms of exo and the lateral rectus is very tight, you cannot do a Y-split LR transpositioning. You may have to do a periosteal anchoring of the globe after a supramaximal recession of the lateral rectus. Like in this case, if you have aberrant degenerations, which will happen in several cases of third nerve pulses, and you need to notice, this case shows you that there is an aberrant regeneration of the lid. On attempting a down gaze as well as in adduction, the ptotic lid gets corrected. And we have seen that you can probably quantify in the amount of the correction of the LPS, how much is the innervation which is there. But fortunately in this case, there is an ortho in the primary position. You may not need to do any surgery because there is an ortho and he's happy. He's only bothered about the ptosis, which he corrects himself by a aberrant regeneration. But there are cases in which there is an exotropia. And in such cases, if there is an aberrant regeneration, you can take advantage of this aberrant regeneration and operate on the contralateral eye to have a fixation duress to improve the lid position in addition to the exotropia correction. Now, this 20-year-old male with outward deviation in the left eye for the last 1 year, drooping of eyelid is there, corrected in some gazes, and associated difficulty in vision on the left side. So we did find that there was an aberrant regeneration. So as we said, we have done a contralateral LR recession of 15 millimeters and MR plication of 8 millimeters. And you can see here, the lid gets corrected along with the exotropia. But the contralateral surgery has been done here. Sometimes there is a situation which is more complex. Now this 44-year-old female patient, she had a 6/12 vision in the right eye, 6/6 vision in the left eye. There was a residual exotropia. Now she had improved, there was a lateral incomitance. Now this was a situation, as you see here, the 9 gazes, 8 prisms basin in the dextro gaze, 16 prism basin in the primary position, but 35 prism basin in the levo version. Now, if you do any surgery, there will be a problem that there will be a correction on one side and overcorrection on the other. So in such demanding situations, we have another option that we are nowadays using, and that is the combined recession of the same lateral rectus. Like in this case, we did a left lateral rectus combo resection, I would say. It's a resection of 6 mm with recession of 12 mm on the same LR, which corrects the primary position as well as induces a much more effect on the lateral gaze. So we have not been able to induce the the consecutive squint. Problems like synergistic divergence, like this child, may be requiring again a Y-split lateral rectus transposition to the medial side. In fact, to my mind, as if this procedure was created for this. It's made for order for a case of synergistic divergence, and these cases have dramatic improvement in the adduction ability in addition to the exotropia. So this is a wonderful surgery for these cases. But there are cases in which you may have some other complex movements, aberrant movements, like this child who has a synergistic innervational downshoot. On attempting to adduct, the right eye actually shoots down. This is a video showing you. As you see here, the right eye is adducting, the right eye is shooting down. Now, if you look at the cases and understand what's the problem, you need to correct the exotropia by doing a lateral rectus surgery, but the inferior rectus can be disinserted and put it into the position of medial rectus. So transpose it to the medial rectus and it will correct the aberrant degeneration to the right way. So this is how the synergistic innervational downshoot can be corrected. So what you need to do is, this is a post-op video now, and you see here that the child doesn't have the SID anymore, the downshoot anymore, and he has a wonderful adduction coming in. So if you can have the localization done, now this is more precise localization, and with the help of the dynamic MRIs, you can confirm your aberrant innervations, and you can have the choice of proper surgery to make advantage or take advantage of this aberrant innervation and correct it more definitely. Conditions like thyroid eye disease may again be causing dysmotility, and you may have to do adjustable sutures in these cases. A skew deviation like this case is there, and we may have dysmotility. It's been talked about by my previous speakers, and these may be managed by the neurologists or the neurosurgeons. Most of the time, we do not handle them, and they have the cases. We are just supposed to examine them and send them rightly. Nystagmus children may be having because of several reasons. It may be a sensory nystagmus in which eye examination, fundus, and ERG needs to be done. The other group of nystagmus that we deal with is the infantile nystagmus syndrome, the manifest nystagmus, or the fusional maldevelopment nystagmus syndrome, or the nystagmus blockage syndrome. Now, these children you will have to deal with as an ophthalmologist. There are spasmus nutans syndrome, like this child here, in which you will see that there is a dissociated nystagmus. The left eye is having a much more amplitude and frequency than the right eye. But whenever you see a spasmus nutans syndrome, you need to do an imaging in order to save the malignant variety. They may be having a neurinoma of the chiasma. A seesaw nystagmus is another situation in which you need to do imaging, and so is the vertical nystagmus, that you need to do a proper imaging to rule out these conditions. Otherwise, most of these three types of nystagmus we may do without the imaging. Acquired nystagmus, you may have this chart, and there is a very nice article in the International Ophthalmology Clinics. You can see that how the localizing lesions can be done in the form when we come across with oscillopsia cases, which are determining the acquired nystagmus. But when we come to the surgical management, just in short, I would say that we shift the eccentric null position, be it a horizontal or a vertical or an oblique, accordingly. The second strategy is to do an artificial divergence surgery as propagated by Spillman. Third is correcting the associated strabismus, especially if they have an esotropia or an intermittent divergence squint. The fourth strategy would be to do 4 horizontal muscle recessions, supramaximal recessions of these. And the Hurtel-Deloso procedure is also a technique which has been talked about, but these two last procedures actually have very little lasting effect. The effect lasts only for about 3 months, we have seen. Most effective procedure, of course, is the Anderson-Kestenbaum procedure, in which the surgery is planned about 4.5 or 5 years of age once the head posture is stabilized, and we shift the eccentric null to the primary position. Like this case, in which preoperatively, and you can manage up to 30 degrees of head turn by just 2 muscles, yoke muscle surgeries of 9 millimeters on medial rectus and 12 millimeters on the lateral rectus. If you have more than 30 degrees, about 40 or 45 degrees, you can add the contralateral yoke muscles as a resection procedure or application. Artificial divergence surgeries are risky. They may have some effect. You need to see beforehand whether they'll be useful by using prisms. But if you overdo, you may have unfusible exotropias. So in short, the nystagmus management, if it is up to 30 degrees, you may do augmented Andersons. If it is more than 40 degrees, you may add resections on the in the opposite yoke muscles. If you have a periodic alternating null nystagmus, you can do a bilateral augmented Anderson's procedure. If you have a fusional maldevelopment nystagmus, you correct the squint. In esotropias, we have found you need to do a posterior fixation suture on the MRs to correct the head turn or a cross fixation which is happening. The IENA Scientia syndrome that we call them as, And the no definite null cases of nystagmus are usually not manageable by us effectively. We have tried auditory biofeedback, acupuncture, supramaximal recessions, Hurtel-Deloso procedures, even medical treatment in the form of brinzolamide, but not very effective. In short, you have to be really an intellectual to work in the field of neuro-ophthalmology and strabismus, and you can definitely get much more desirable results with your inquisitive approach, and definitely helped by Dr. Sachin, as he has told you, and the proper examination techniques. So I would like to end my talk here. Thank you for a very patient listening. We can do lots that is possible for these children. Thank you.
Thank you very much, sir, for an excellent presentation. Any comments from the panel?
Yeah, Rohit, I just wanted to ask some question, but at the outset, I'd like to thank, it was a wonderful session on all the disorders of ocular motility. So I want to congratulate INOS. So for Dr. Pradeep Sharma, two questions.
Yes.
When you plan to do an adjustable VRT and against modified Nishida, is there an amount of deviation that you choose, or limitation of motility, or you can do it for any cases of severe? That's one. And secondly, regarding plication, how is your result as compared to resection? And it's normally said that even if you do plication, it's not reversible unless you do it within 2 weeks. What's your opinion? And it's also said that the ciliary vessel is not spared. So just wanted your comments on that.
Okay. First is about the choice of surgery between a partial VRT cross-section versus Nishidas. I think you may choose case to case, because depending on your ability, for example, if there is a child you can't adjust, then you may better do a modified Nishidas procedure and hope for the best, because you will have to, the medial rectus would the only one which will be required for adjustment, and you can just hope for that. If you have an adult, then you can do a better control on the partial VRTs, because it will take care of the vertical incompetence as well as torsion also when you're adjusting. So, I mean, this can be the choice case to case to choose between the modified Nishidas with the MR adjustable or a partial VRT which are on cross-section adjustables. The second thing is about the plication. Now, what I have seen is that the amounts that I do for resection, and we did the same amounts of plication and we got the same results. So I see that you do not have to change your surgical dosing, whether you're choosing to do a resection or a plication. The second thing is about the adjustment. It is true that the plication, you can easily adjust within a week. You can just undo. It is it's like two-step adjustment. That means you can either fully undo. You cannot have a release of the suture and have as in adjustable recessions, of course, but it gives you an option of correcting the overcorrection which is there. And usually it may be in the first week that you will notice the overcorrection. So it works well. Very rarely you would have to do an adjustment after 2 weeks. So this situation usually has not happened to me, that I would have to adjust a plicated muscle. But it is true that over a month or 2 months' time, it resorbs very nicely. The lump disappears in a month's time, and